I've been involved in a meeting in Brussels last March, and we discussed the topic of lung cancer screening in Europe and the opportunity to start implementation on a large scale. We agree that evidence in terms of mortality reduction is ready for implementation. So we have scientific evidence that screening works. However, from a political point of view, the European Commission probably needs more details on how to move and how to implement the screening in the countries, in the European countries, in terms of methodology and the efforts, also in terms of economical resources.
It's very important in a screening program that you focus on asymptomatic patients. If you let just come in all the patients who were smokers, they have symptoms, they cough, they have thoracic pain, then you have a delusion, you know, then you will have stage 3 and 4 in your screening program. That's why it's very, very important that you have asymptomatic, and we ask the people several times to be sure that they do not have any symptoms. So far we had one stage 3A cancer. The patient had chemotherapy and then operation, and all the other patients were in stage 1 and 2.
This is true. There is an increase in epidemiology rate of non-smokers cancer, lung cancer. It still remains a minority of the problem, around 10% in men and 15–20% in women. So if we would not have the smoking behavior, lung cancer would remain the 6th cause of cancer death in our countries. So it's true that is increasing the problem, but still remain a rare disease in non-smokers. However, for the future, I believe that the development of molecular markers will be very useful to test also non-smokers. It's true that the risk is much lower compared to smokers in the general population, so we must put very well in balance the risk and the benefit of having large-scale screening in this category of people.
Yes, indeed, traditionally, lung cancer screening programs should be dedicated to high-risk population. You've quoted some of the risk factors, but indeed the increasing incidence of lung cancer in non-smokers and females non-smokers will force us to reconsider, and maybe by completely revolving the order with which we subject individuals to screening, by using breath analysis first and then CT scan only if the breath analysis should give us a positive result, then this would be a way to contain costs and risks in terms of exposure to radiation for these young, usually young women who are not smokers and end up with a pulmonary lesion of unknown origin. So this could be a policy, a protocol, even more so, a strategy if you include the cost effectiveness of the entire procedure.
You have to do a risk stratification. If you start to screen 30-year-old women, you have to screen 100,000 to find one, you know. So the aim of this program is to do a certain risk stratification where we have really a good chance to find some lung cancers without screening the whole population.
Many investigators are focusing attention on developing molecular markers. We also have done a lot of work on this. We have identified the microRNA signature in the blood. The problem is the validation of this tool. So I believe that we need still some years of research activity before these markers will become ready for the clinical use. In the meanwhile, I believe we must use the best tool we have, which is low-dose CT, for starting a large-scale screening implementation, and continues our effort in research in this field. So probably I see 5 and 10 years before to have a clinical use of molecular markers and breath markers.
In 1991 came out the first publication about low-dose CT screening, and now 25 years later we are still talking about should we do it or not, you know. And in the meantime 100,000 of people die of this disease, and we could do something for these people, and we just lean back and do nothing. And there is no other test at this moment which has proven that it decreases mortality in this patient. So if there is a breathing test, I'm the first one who will utilize it if I see using this test decreases the mortality of these patients. But this data is not here. So why shouldn't we deal with the data we have?
But you have a signature, a breath print for lung cancer, but also a breath print for breast cancer, breath print for colon cancer. You can have the whole setup. The world of screening is going to be revolutionized.